Hey everyone, my name is Marisela Lara, and today I'll be talking about Parkinson's disease. Specifically, I'll be going over the definition, symptoms, diagnosis, molecular mechanisms, and treatment options available. Let's get started. So, Parkinson's is a progressive neurological condition that results in degeneration of dopamine-producing neurons in the substantia nigra part of the brain. I'll be talking more about the importance of this area in the molecular part of the presentation. Parkinson's is also considered to be a chronic and progressive disease that is not fatal, however, it's very debilitating for the individual because they have no control of their motor movement. It's also a precursor for many other diseases such as schizophrenia and dementia. In terms of the symptoms, there are two major classifications, the first one being non-motor related symptoms. That includes anxiety disorders, depression, sleep disturbances, and olfactory dysfunction. The motor-related symptoms that includes rigidness, which is when muscles are tense and contracted, resting tremor, that's characterized by trembling that's most obvious when the patient is at rest, bradykinesia, which is the difficulty in initiating movement, and loss of postural reflexes, such as poor coordination and poor balance. The age of Parkinson's usually affects 2% of the population that's older than 65, with the average age onset being 62.4 years. However, most cases develop between the ages of 50 and 79. Notably, individuals who have Parkinson's and are under the age of 40 are referred to as having a young onset of Parkinson's, and it's theorized that LRRK2 mutations, which is a gene I'll talk about in the next few slides, plays a significant role in modulating the amount of dopamine made available in the basal ganglia. Below the picture shows the differences between a healthy patient and a Parkinson's patient. This is primarily due to differences in dopamine levels. As you can see, it's much higher in a healthy patient. In diagnosing Parkinson's, unfortunately, there is no standard objective test. For example, you cannot get a brain scan or a blood test in order to get a definitive diagnosis. However, doctors and neurologists have looked at motor-related symptoms and medical history of patients. Patients are also able to take the Hoehn and Yahr scale survey, which is a 1 to 5 point system survey that allows patients to rank the severity of their symptoms. For example, scoring between a 1 and a 2 is usually an indicator of the early stage of Parkinson's. 2 to 3 is the mild stage, and 4 to 5 is usually the advanced stage in which symptoms have been chronic and have been occurring for several months. There are also several risk factors involved with Parkinson's in which men are 1.5 times more likely than women to actually develop Parkinson's, specifically elderly white men. The environmental exposure to toxins such as pesticides also increases the chance and risk, specifically in farm workers. And there's also the genetic component of having a close relative of Parkinson's. So let's talk about the LRRK2 gene mutation. LRRK2 is an abbreviation for leucine-rich repeat kinase, and it's located in the long arm of the chromosome 12 as seen in the picture to the right. People usually inherit 2 copies of this gene, one from each parent. But what does it do specifically? Well, it's theorized to modulate the levels of dopamine available in the substantia nigra part of the basal ganglia. Oftentimes, mutations that occur that do not allow for the proper formation and proper function of dopamine-producing neurons in the substantia nigra. Moreover, alpha-synuclein is an abnormal filament found in presynaptic terminals of the substantia nigra, and unfortunately, they prevent the release of dopamine neurons from the presynapse onto the postsynapse and inhibit motor coordination. I'll be talking more about this in the next slide. So let's go over the basal ganglia. This is a collection of nuclei found on both sides of the thalamus. Dopamine is produced in the substantia nigra, which is basically a hub for densely packed dopamine neurons. Dopamine has an excitatory effect on cells found in the basal ganglia, specifically the striatum that's made up of the caudate nucleus and the putamen. The excitatory effect is usually modulated by D1 receptors. However, dopamine also has an inhibitory effect on striatum cells using D2 receptors. These receptors are specifically involved in turning up motor activity or turning down. In Parkinson's disease, aggregates of Lewy bodies impede the substantia nigra from producing dopamine. This also causes a buildup in plaque. As you can see in the picture on the left, this is a normal, healthy substantia nigra. However, as plaque buildup occurs through these Lewy bodies that is basically a neurotoxin to the brain, there are holes or patches in this area, and that depletes the amount of dopamine available to D1 receptors in the striatum. The other case is the LRRK2 gene, which basically malfunctions or mutates and cannot modulate the number of dopamine neurons available in the basal ganglia. It basically turns off dopamine production. So let's talk about the therapies and pharmaceuticals available for individuals with Parkinson's. Unfortunately, there's no cure for this disease. However, there are several wonder drugs that slow down the progression of symptoms. The first one and the most popular one is L-Dopa or levodopa. It's commonly prescribed and most effective in controlling symptoms and slowing down their progression. This drug is transported into the nerve cells and produces more dopamine. However, it does have its pros and cons. The pro being the on period in which it's first introduced and effectively works in slowing down the progression of symptoms. There's also the off period in which after several months or years, the medication begins to wear off as the brain adapts to the levels of dopamine being introduced into the body. As a result, L-Dopa is given at higher dosages. Unfortunately, the side effects associated with this increase as dosages also increase. So patients oftentimes feel an increase in the cramps, vomiting, and abnormal bleeding. There's also MAO-B inhibitors, and MAO-B is an enzyme that is used to break down dopamine. By using these inhibitors, such as Zolapar, the breakdown of dopamine in the brain is prevented. There are also dopamine agonists, which increases the amount of dopamine levels in the brain and can also mimic effectively the activity of dopamine. It's usually given during the early stages of development of Parkinson's. They're often given at low dosages and titrated upward as tolerated until optimal therapeutic effects and benefits have been experienced by the individual. Lastly, and in my opinion, the most effective type of treatment is deep brain stimulation, which is the picture to the right. This is a neurosurgical procedure reserved for individuals with advanced forms of Parkinson's, specifically those who have tried a number of medications for their motor symptoms or have experienced several off periods due to L-Dopa. Deep brain stimulation is designed to reduce such on and off motor fluctuations. This is usually done by implanting a permanent electrode into the selected deep parts of the brain. Then, 2 permanent battery-operated pulse generators are implanted under the skin, specifically under the chest or the abdomen. The pulse generators are connected to a stimulator electrode via wires that are tunneled underneath the skin all the way to the brain that has the patch electrode. The pulse generators are then designed to suppress motor symptoms of Parkinson's and allowing the reduced use of L-Dopa.